Go ahead and raise your toes up like we were talking about. Good. So you get a nice arch there. Keep that arch up. Hey guys, welcome to the Gait Geeks podcast. Today we're going to be talking about the short foot exercise, and some of it's, well, I don't know if we want to say pitfalls, but just kind of the way we do it and what it means. We found a great paper when we were looking through literature this week. This was pretty cool. This was in Gait and Posture. It's a relatively newer paper as well, 2020, I believe. But anyway, plantar intrinsic foot muscle strengthening exercise affecting dynamic foot kinematics. And the exercise that they used in this particular study was the short foot exercise. So before we go through this real quick, let's, Scott, can you put that video up, and can we narrate while the video's on or no?
I don't know if we can narrate when the video's on, but what we can do is we can play the video, and if we need to play it once or twice, then we can come back, pull it, and talk about
let's go ahead and do that, talk about that, and then we can actually talk about what they did in this paper. Go ahead and raise your toes up like we were talking about. Good. So you get a nice arch there. Keep that arch up. Perfect. Now put the toes down, but maintain the arch. Good. And now relax. There you go. Nice. So basically, we have people in a tripod stance posture. We have them raise their toes up, feel the arch engage as well as the windlass, and then have them slowly relax their toes, but try to maintain the arch. Hold it for 20 to 30 seconds. That's basically the short foot exercise. Works fairly well. Helps to get those foot intrinsics. We know that the intrinsics fire from mid-stance through pre-swing. That's when they're supposed to fire and do their job. They also assist the tibialis posterior in slowing pronation motion of the foot and also assisting in resupination of the foot. This particular study was pretty cool. It was, so first of all, they had a lot of participants, but then they disqualified most of them. And they ended up with 20 people left with pes planus. And they basically assigned them to either, the beer and Doritos group that didn't do anything or the exercise group. But the exercises, here's the cool thing about it. They did 8 weeks, 3 times a week. That's it. That's all these people did. And then they measured interventions. They looked at number one, navicular drop, and we'll talk about what that is in a minute. They looked at something called dynamic navicular drop, which is pretty cool. That's not something you're probably going to be able to measure unless you have motion capture software in your office, but you can do that. They looked at cross-sectional area utilizing ultrasound, and they also looked at something called the FPI, or the foot posture index, the 6, in that. And what they found was that people that stuck to this exercise program had decreased speed of pronation. They had an increase in their decrease in their navicular drop, increase in arch height, and they also had improvement in their FPI. So
just in the rear foot, in the calcaneal inversion eversion metric, I believe.
Correct. Yep. So just at less calcaneal inversion and eversion, but pretty cool when you're thinking about looking at this with not a lot of application. When we have people in our office, and I'm pretty sure you do the same, Scott, what do we tell them? We tell them do the exercise 2 to 3 times a day. You're going to do them pretty much every day. I always tell people I'd way rather exercise for 1 minute 10 times a day than 10 minutes once a day. So we're going to try to spread it out, build capacity, skill, endurance, strength.
I've also something to think about. I really like the way you talk, and they talked about doing the actual navicular drop or the actual exercise itself, that short foot exercise. I've seen people talk about like literally trying to make their foot short by drawing in the toes actively, and I think some people get it and other people don't. But I think this way is almost like it's a you can't miss it, right? You lift your toes up, keep that position, slowly lower your toes down without losing that position. I think it's a very, very easy way to kind of accomplish the goal of the exercise. It's very, very simple, and people seem to get it a lot quicker.
Yeah, you engage the windlass to kind of assist propping everything up. And then, what's going to maintain that arch generally when we're walking? Well, the foot intrinsics for one, right?
Mm-hmm.
Your tibialis anterior to some degree, your tibialis posterior to some degree. That's basically, and then, okay, so flexor dig longus, extensor dig longus, flexor hallucis, extensor hallucis. Those guys are all going to help. But largely, when you look at muscular attachments, the tib anterior and the tib posterior are the big players in this because they attach, especially the tib anterior, to that navicular tubercle. That's what's going to help pull up and maintain that arch and also help to decelerate pronation during that first part of gait for the TA, and then the TP for the second part of gait as we're going, mid stance and we get into the further cycles there. So I really like it the way we're showing it here. This is not out of the article. This picture is actually from a blog post that Dr. Allen wrote for us a while ago with the Gait guys, but it was just such a great picture. I thought, as far as showing kind of how to engage that. And we also use that same method when we're going to do the navicular drop test. So the interesting thing also to the study about me, and then I'll let you hand the mic over to you, Scott, was that, they measured those 4 parameters. They talked nothing about ultrasound in the results, which means unlike some other studies that we've seen that use other exercises in addition to this one, okay, there was no change in cross-sectional area of the foot intrinsics that they were measuring with ultrasound. Otherwise, that would have been mentioned in the conclusion. But pretty cool that they were able to slow stuff down.
Yeah, I agree. And the navicular drop is something I use all the time. I think it's a very quick and dirty way of assessing how much mobility there is through the foot. And when somebody functions, it's more of we'll call it a static measurement. Oftentimes, I know there's a dynamic way to kind of measure it, which I don't do that much at all, if at all. So I'll kind of turn it over to you for that. But from the static perspective, you see what that navicular drop is, and anything greater than, in my hands, like 10 millimeters is said to be a excessively pronated foot. Less than 5 is like a really supinated foot. And then somewhere in the middle from 5 to 10 is that neutral, normal collapsing that is needed with shock absorption, right? The shock absorption component of pronation is important. So, moving too little is bad, moving too much is bad. Somewhere that in the middle is just right is what we're looking at there. And it's one of those things where if you have, adequate mobility through the subtalar joint and in that navicular drop test, but meanwhile, when they walk function, they're not using that range of motion, we can try to decipher why, or if they're using all of that motion, that may bring up some other questions. Or so it's just a good way to kind of assess. Another thing I like to use this test for is, somebody that has a pretty significant navicular drop test, in my opinion, and in my hands, may be a better candidate for somebody to accept an orthotic. Because again, if they're able to achieve an arch or have an arch, and then you give them an arch to maintain some of that stability, it's going to be somewhat more comfortable for them, as opposed to somebody that's got a really pes planus foot and doesn't have a whole lot of mobility, and then you stick an arch in the bottom of their foot. It's not going to be the most comfortable thing. It's almost like a rock in their shoes sometimes. So, somebody that moves a lot, in my opinion, maybe some of the easier ones to correct, because I'm always not trying to fully correct and limit all of motion, but I want to limit some of that motion. And again, having somebody that's got a large degree of drop displacement is probably the easiest and best suitors for an orthotic in my hands. Do you have any thoughts using that as a determining factor, Ivo?
Yeah, we do. We use, I would say, along similar lines. We'll basically have people, stand in what we call a tripod stance. So your heel, the base of the head of the first, head of the fifth are on the ground. And then I have them dorsiflex their toes. If the arch comes up and then I have them totally relax the foot and the arch goes down, they're generally more of a candidate if we're going to use some kind of supportive measure for something like that, as opposed to somebody that has very little motion available to them. So that tells us, one, not only do they have an intact windlass, but also gives us a little window into what's going on as far as the intrinsic musculature and what's going on with those guys. So anyway, I just thought it was kind of interesting that they were going through that. Navicular drop test. So 2 different ways. Well, actually, there's a lot of different ways to do this. So the original one was described by Brody. He was looking at runners at that time, looking at foot pronation and people that being at an increased, what do you want to say, propensity to have an
Yeah.
injury, plantar
Yep.
fasciitis specifically,
Mhm.
as far as that goes. So palpate the navicular tubercle. The way they describe it, or he describes it in his paper, is you mark the navicular tubercle. I like to just use a Sharpie when we're
Mhm.
doing that. And then have the person put their foot in a supinated posture, but that's sort of the language that they use. And then from there, measure the distance just using a ruler. We do it in millimeters just because it's easier than in 3 seconds or something like that. And then have them totally relax the foot and just take the measurement again. And you're looking at that difference between the two. So we're looking for 5 to 10. Okay, that's kind of, some literature says 5 to 9, some says 6 to 10. So 5 to 10 is kind of a good thing. If they're, navicular's on the floor, that's not a good thing. If it doesn't move at all from up above, then they have a rigid foot, and you probably don't want to be using an orthotic, but you may want to use some posting in their shoe,
Mhm.
if they had like a 4-foot valgus with a cavus foot or something like that, which is a common
Correct.
scenario, to kind of help them out a
Mhm.
little bit, but that's not necessarily a full-blown orthotic. But that's
Mhm.
that's how they describe it. The only difference we do, and we showed that slide before, is we have the patient dorsiflex their toes and engage that windlass. Measure the tibial tuberosity, not tibial tuberosity. That would be funny. We measure here we go, the navicular tuberosity to the ground at that point, and then I just have them totally relax the foot, and I measure that same distance.
Mhm.
So it's similar to the way I do it, but I don't tell the patient to cue to supinate the foot. The reason for that is when a lot of people supinate their foot, they fire their long flexors. Okay, and we're trying to keep the long flexors out of this and get an idea of what the intrinsics look like, not what the long flexors look like. Because if you just fire your long flexors, you can definitely formulate an arch down in that area there.
So I tend to do it kind of a combination of both. How's that? I like to do it where I get them in a relaxed stance position. I too mark the navicular tubercle with a Sharpie. And then I'll actually manually invert their foot or supinate their foot myself to a position where I feel is one in which their foot's not rolling too much off the medial side. So they're inverting their foot, but their big toe is kind of still staying in contact with the ground, and see where that position is there. Almost like I call it the LMI of 0, where their lateral malleolar index of 0, where their lateral malleolus lines up with the same plane of their lateral foot. And once I get that position, then that's their high position in my hands, and I too measure the distance in millimeters, and that's where that 5 millimeters to 10 millimeters is said to be somewhat normal. Greater than that is a more of a planus foot, and less than that is more of a supinated foot. So or a rigid foot versus a flexible foot. So that's kind of how I do it. It's very similar to both mech, and they have a little bit of a similarity to both. But I think any of that can be appropriate. I like to do it in weight bearing. I don't know about you, Ivo. I
yep,
like to do
yeah,
it in weight
that's how we
bearing
do it.
because, again, I think the weight bearing, especially in the relaxed stance position, really tells you how flat that goes when the person is actually ambulatory and walking. Because this is a static measure, you're trying to get as close to a functional position as possible, and non-weight bearing is not that. So that's why I like it in stance.
And if you want to be really nerdy about it, you can do it 3 times and take an average. As far as that goes, we don't do it that much. It's more of a benchmark, the way that we're using it in the office. If you're even doing it at all, that's wonderful. I mean, you're
Hmm.
using an objective measure, and you can do this to measure the efficacy of the whatever foot exercise program you give the people, whether it's hopefully not, but towel grabs or something like that, or picking up marbles, or you're giving them like the lift spread reach exercise, or you're giving them toe yoga or whatever, and you can utilize that over time and be able to track hopefully progress in that
Hmm.
particular case.
Yeah.
They also did dynamic navicular drop. Now you really can't do this in your office, although you know what, I haven't tried it with mocap software to see how that works, but basically what they're looking at is how does that navicular tubercle change as we're going through a gait cycle. So at initial contact versus mid stance where it should be fully pronated. I have not tried that yet. Another thing that Scott's been using it for a long time. I just
Yeah.
started using it, is the new Run Stride product, which is a little IMU. These are
Hmm.
pretty cool.
Hmm.
And they go on your shoes, and there's a sacral sensor, and it'll measure degrees of pronation supination. So I imagine you could use something like that, just having them stand up, do a short trial of 15 to 20 seconds of having them do it several times, and then you'll be able to actually look at the graphical info on it. Kind of a long setup to do a test that shouldn't really take you too long, but it might be kind of cool for us to try some of that in some of the seminars.
And I do that. And when I said
people.
when I don't do traditional dynamic, that would be what I do use is that computation, I guess, that comes from the algorithm in the IMU itself that tells you the displacement when they're walking. So I guess that is dynamic, and I guess it is somewhat of a navicular drop. But I never have previously classified it as a dynamic navicular drop, although that's in essence what it is. So that makes good sense.
It would be interesting to see, just kind of talking and thinking out loud here, because you and I have been talking about standardizing a protocol for the run stride. So when we're teaching it to people, the data equals the data. If you do it, I do it, everybody does it, it's the same. We could try sticking the run stride over the navicular tuberosity. Run scribe, sorry. And do the put it over the navicular tuberosity, and then go through with the understanding there, calibrate it in that position so it thinks that's neutral, and then calibrate the amount of motion there. That's something we'll have to try.
Yeah, I'm just not sure. I'm not sure how that'll work, and this is totally off key for this, but I think it's calibrated, and the algorithms are based on the position of it being in the over the laces of the shoe. So I don't know what that would do to the X, Y, and Z axes of the IMU, and how that would then correlate with the readings that it gives you in terms of the maximum pronation and maximum pronation velocity and all of that good stuff that comes along with the run scribe. I'm not sure if that would mess up all of those readings based on just the orientation of it.
It definitely changes them. On purpose, right after I got it, I did a regular walk, and then I went out with a walk where I purposely skewed it medially because I wanted to see what that would do. And the data shows it was accurate, but it showed that I was pronating way heavier, on that side because it was more medial, as far as the excursion goes. But that's something we could certainly go.
Absolutely.
So they did diagnostic ultrasound. They looked at cross-sectional area. And then the last thing is the foot posture index. You want to talk about that a little bit, Scott?
Sure. So the foot posture index is pretty it's a pretty neat thing. You've got to get good at identifying certain characteristics and landmarks. I don't think just out of the box using it for the first time you're going to be all that great at it. I think there is a little bit of a learning curve to it. There is a six category type of system in which you rate. And you're basically looking at things such as tailor head palpation, the curvature of the super and lateral malleoli curvature, looking at the calcaneal-frontal plane position, prominence of the tail and navicular joint, congruence of the medial longitudinal arch, and then is the foot abducted or adducted, looking at like the too many toes sign, that kind of stuff. And the more or the higher the number as you score this, the more pronated the foot, and the more negative the number, the more supinated the foot. And you just rate each of those based on the criteria that the test kind of, or the index kind of gives you. It's pretty self-explanatory, although again, like I said, being truly with your and intra-rater reliability may take a little bit of time just to get comfortable knowing what you're looking at. But in my hands, I don't do it all that frequently these days, but it is a pretty easy thing to do and doesn't take too much time. Is this something you do often in your office?
No, I mean, when we're doing any kind of thing that's going to be in a paper or something like that, you obviously need objective measures. So this is one of the ones that can get used, but it's stuff that I all look at, but I don't give it a physical score on my exam when I'm going through it. But this particular paper did talk about it because it was one of the 4 parameters that they were measuring.
It's a great thing to use in research. I think it's a great thing to help classify and quantify what the foot looks like in research studies. Again, absolutely could be used from documentation purposes in your clinic to give you that idea. Is it a supinated foot? Is it a neutral foot? Or is it a pronated foot? And give you some reasons why you're saying that, based on this index. But I think most people will look at a foot and be able to tell you just by looking at it Is it a really high arch foot? Is it a really low arch foot? Or is it somewhere in the middle? And that's kind of what this does, but it just puts some qualifying numbers to the assessment that your eyes are telling you.
Yeah, and the other thing that with the test, when they're talking about it, when you read through the FPI paper, I forget who the author was, but we have it in the note thing in the slide, is that if you don't measure one of them, or if you can't because of swelling, then just omit it.
Mm-hmm.
Which I'm kind of like, I don't know if that's necessarily such a great idea,
Right.
but okay, as
Exactly.
far as that goes. But anyway, so the bottom line, yeah, foot exercises seem to work. This particular paper is showing us that 1, it decreases navicular drop. 2, it slows and decreases dynamic navicular drop, and improves the amount of inversion, eversion of the calcaneus on the FPI, which is pretty good. And this is only looking specifically at the one exercise, the short foot exercise. There's lots of other exercises. You remember this was kind of popularized by the Czech people back in the late 80s and early 90s, when that whole rehab, Collage and Vladimir Yanda and all those people were first getting known here in the Western world. But pretty cool stuff. And the fact that a little bit goes a long way. I mean, exercising, 3 days a week for 8 weeks made a difference. You can get people to do anything. I think that can be a really good thing. So this is another tool you can put in your toolbox. We could talk a little bit, so if a person does have pes planus, they're at an increased risk for developing a plantar fasciitis, because of that windlass is not working quite as well. And faulty things that, because of the weakness of the musculature there. They can be at increased risk for knee problems, depending upon the rest of the morphology, because the foot's in a pronated position past mid-stance. As we start to try to go into supination, then you're basically macerating the meniscus between the femur and the tibia as we're trying to externally rotate. And if you remember that, from initial contact to mid-stance, the tibia rotating internally, the femur is rotating internally, the tibia has to rotate faster than the femur. Okay, and that's going to be eccentrically checked by the popliteus muscle. And then for the second part of the gait cycle, when we're trying to supinate, the femur externally rotates, the tibia externally rotates, but the femur has to externally rotate faster than the tibia. Otherwise, we're going to macerate the meniscus, and that's through concentric contraction of the popliteus. And the peroneus plays in there. There's a bunch of other factors that we're not necessarily talking about today. But when you have those intrinsic musculature, along with dorsiflexion of the ankle, along with flexion of the knee, along with contralateral drop of the opposite side, along with sinking of the ankle mortises around the talus to absorb some of that traction, it just gives us another attenuating mechanism that we can utilize to try to help to slow things down. And then theoretically, one more system that can have a problem that we need to kind of look at when we're evaluating our patients.
Agreed. I think all of it is a great tool to kind of whether it be strengthen the foot intrinsics, controlling that motion by alternative means such as orthotics and taping or what have you, are all tools that we can use. And I think the cool thing about this is that it's so hard to think that small little muscles like we're talking of the foot intrinsics, like it's not something that you're ever going to manually muscle test. A foot intrinsic, a lumbrical, let's say, or something along those lines. But to have them working together, and that's kind of how I see the foot intrinsics. Like they're a group of muscles that you're not going to isolate, let's say, one or the other. You're going to look at the group as a whole and how they function as a whole to control some big landmark movements of either the foot and the ankle and the tibia, and as Ivo said, up the chain. Having a study like this that really shows that those small little muscle groups can be stimulated in a fashion to significantly alter the biomechanics of some pretty long levers, let's say, is pretty neat in my opinion.
Yeah. It's remarkable. And remember about those muscles too, in addition to, power in numbers, them being able to work together and create, as opposed to just one lumbrical firing, having them all of them fire, they also act as proprioceptive sentinels, and they're going to appraise the cortex of where your foot is in space. Remember, we have all of that muscle spindle and Golgi tendon organ afferent information traveling up through the spinocerebellar pathways, which is going to in effect, provide more afferent input to our cortex, which is going to allow us to more effectively dampen that activity through some of the descending pathways that are going to come down to make that work that much better. So you can make an argument, going back to the methodology, because I talk about, dorsiflexing the toes and then relaxing. Well, if you're doing that, you are going to work the anterior compartment, the EDL, the EHL, and stuff like that. Sure you are. Absolutely. But they don't work in isolation, not unless you take Botox and you go in and you start injecting little parts of nerves and stuff like that. They're all going to work together, for kind of a common cause. Do they fire different temporally? Well, according to the EMG studies I've seen, yeah, they do, and everything kind of has its time in the gait cycle that it's supposed to work. I have not seen any, and maybe you have, Scott, I haven't seen any specific work looking at the intrinsics individually as far as temporally firing. I've seen some on abductor hallucis, some on flexor hallucis brevis, and I've seen some that's just more looking globally. And I think part of that is we have a really hard time sticking an EMG needle into a muscle and being able to measure that during an activity without having that, nociceptive input. You can't really go through the plantar surface of the foot to look at the plantar interossei. We could go through the dorsum of the foot and count through on layers and stuff like that. And you could do ultrasound to make sure you're in the right spot. But, contracting needles or contracting muscles with needles in them is not comfortable.
Especially in the foot where the amount of movement is so everything's so tight, the quarters are so tight in there that you may get some overlap and some, especially when a muscle contracts, it's going, the needle depth is going to play. It could be a disaster, actually.
Well, yeah. And then just look at an ultrasound of the foot. You want to see complexity and a compact design. When you're in the cadaver lab and you're dissecting a foot out and you're looking at it, it's fascinating to look at the 4 layers. But then to think, gosh, I got 4 layers in this much tissue. It's pretty incredible, and they're pretty flat. Largely, when you're using an ultrasound, you have to just angulate the probe different ways to get like the different muscles so you can actually tell what they are. It's not very, very plain like when you're looking at a gastroc or a soleus or a deltoid or something like that, where it becomes super clear. But yeah, again, really neat, power in numbers. So add this to your clinical toolkit, guys. We've got a couple other papers we found when we were looking at this paper, so we'll be talking about them. We do have a foot exercise course that'll be coming out, probably be early next year, as far as that, looking at from a research base what some of this does, some of the effects of these exercises, and then on the few papers that exist out there, combining exercise with an orthotic device, which we've talked about on a couple podcasts, I believe, where your outcomes tend to be somewhat better as far as that. And you're just kind of giving them assistance. You're giving them more of a mechanical advantage till they can start to rehab those muscles, and then we can work from there.
Yep. Sounds great. Well, guys, thanks again. Hopefully today there was a bunch of stuff you got out of there, whether it be the navicular drop, if that's something you're not using currently in your practice, a great tool. Same with the foot posture index. And again, that short foot exercise. Most everybody that's working with foot strengthening is doing some form of that exercise. So a couple of different ways to cue it and start it, but all very, very valuable. So hopefully you got something out of it. Enjoy the show, and we'll talk to you next time.
Thanks, guys.